Excellent. Let me go ahead and share my screen here. All right. So I just want to start off by thanking Catherine and for allowing me to present this. This is a little bit of a little bit of a didactic, a little bit of challenging cases that have come up in recent years as we see a shift from our antiretroviral therapies, including Hep B active treatments, to moving away from those, particularly with the availability of long-acting injectable antiretroviral therapy. So what I wanted to do is go through a little bit of the data that we do know, and then talk about some of the topics specifically about hepatitis B reactivation, acute infection, and of course current knowledge gaps in people with HIV as it relates to these ART switches. I've embedded a few of the cases within this discussion, so I hope that we can pause during those presentations and get everybody's feedback, as I don't think there's a clear consensus, so really looking forward to everybody's input. So just by way of outline, I know we've talked about hepatitis B and people with HIV, so we'll briefly review. We'll talk about the changing landscape of antiretroviral therapy, just knowing that not everybody on the call has familiarity with our current HIV treatment strategies. And then I've picked 3 clinical scenarios that I think will allow for a robust discussion. Oops. So first, very briefly, we know chronic hepatitis B is generally defined as a detectable surface antigen for more than 6 months, is present in about 5 to 10% of people with HIV in the United States. And we know in people with HIV and hepatitis B co-infection, they have a much worse prognosis than in hepatitis B monoinfection alone. And this is because we can see increased hepatitis B viremia in people with HIV, more rapid progression to cirrhosis, increased risk of hepatic decompensation, development of hepatocellular carcinoma, and liver-related mortality. And because of that, current recommendations are to include Hep B active antiretroviral therapy in people with HIV and chronic hepatitis B. And we know that when people have lapses in those hepatitis B active therapies, we can see hepatitis B reactivation with both an abrupt rise in both hepatitis B viremia and frank hepatitis with liver aminotransferase elevations. Additionally, we can see acute hepatitis B, generally defined as a detectable surface antigen less than 6 months, in the presence of anti-core antibody IgM specifically. And what we've seen in a few observational studies is that it seems in people with HIV, they're more likely to progress to chronic hepatitis B compared to those uninfected. And Hep B active antiretroviral therapy in people who are exposed to hepatitis B, may actually decrease the risk of acquisition and subsequently decrease the risk of that chronic hepatitis B development. So how do we approach hepatitis B prevention and treatment in people with HIV? And again, just to briefly go through some of the serologic profiles that we can encounter in clinical practice, we do see among those people who have detectable surface antibody, again, in isolation is consistent with Hep B vaccination, and in the setting of HIV would require no additional routine monitoring from the hepatitis B standpoint. Among those who are Hep B non-immune, that is no surface antigen, no core antibody, and no surface antibody either, all people with HIV should receive hepatitis B vaccination, and that surface antibody should be confirmed as detectable following completion of that series. And as we discussed, chronic hepatitis B with detectable surface antigen and core antibody, again, should have Hep B active antiretroviral therapy included in their regimen, generally with tenofovir, either tenofovir disoproxil fumarate, tenofovir alafenamide, with emtricitabine or lamivudine, essentially dual active therapies to control that chronic hepatitis B. And then in areas which are a little bit more challenging is this area of resolved hepatitis B infection, where there's no detectable surface antigen, but there's core antibody detected, again, from prior hepatitis B exposure, with or without the presence of surface antibody. And in the setting of hepatitis, or in the setting of HIV infection, generally correlates with prior infection. In some recommendations, it is suggested to first check a hepatitis B DNA at entry into care to inform treatment. Yet there's not great guidelines or recommendations on how to then manage these people if they do have detectable DNA. And specifically in people who have surface antigen negative core antibody positivity, they do not require a Hep B active therapy as part of the guideline recommendations for treatment. But in the setting of that isolated antibody to core, people with HIV should receive Hep B vaccination with the goal of achieving a detectable surface antibody of greater than 100 international units per milliliter. And what's interesting is that this comes up quite frequently because estimates suggest that about 20 to 45% of people with HIV do have isolated core antibody. And so this is important because it can come up in the setting of how we think about reactivation and how we approach occult hepatitis B in people with HIV. And so again, just briefly, definitions for hepatitis B reactivation, depending on the study, may have variable definitions, but generally looking at people who are now newly positive for surface antigen, newly detectable hepatitis B DNA if none was present prior, or an increase of at least a log 10 in the hepatitis B DNA. And we can see spontaneous seroreversion, that is going from a negative surface antigen to a positive surface antigen spontaneously in people with HIV. And again, from observational studies, there are ranges that this can occur in 0.02 to 0.2 per 100 person year. So again, not clear on the exact risk. And it's been reported in both people on Hep B active ART and on people not on Hep B active antiretroviral therapy. And in these observational studies, it seems that this spontaneous seroreversion is associated or can be associated with lower CD4 count. So again, more immunosuppression, higher HIV viral load off therapy, and then potentially some other immunosuppressing conditions, whether it be chemotherapeutic agents, end-stage renal disease, and other similar factors. In addition, we can see a phenomenon of immune reconstitution inflammatory syndrome, or IRIS, in which people have profound immunosuppression, they're started on antiretroviral therapy, and over the course of weeks to months can have a robust inflammatory response as their immune system is sort of kicking back on. And we can see hepatitis B reactivation in that setting, both in people who are on, again, Hep B active therapy or on therapies not active against hepatitis B. And to contrast that, or to talk about the occult hepatitis B infection, this is in people with serologic profile with no detectable surface antigen, but detectable core and detectable Hep B DNA. And the prevalence of this is quite wild because estimates suggest anywhere between 13–15%, but these reported observational studies can have a dramatically wide range from 0% prevalence to nearly 90% prevalence. So it really depends on what population you're looking at. And at least in people with HIV, the clinical significance and the management remains a bit unclear. And while there are studies in people without HIV suggesting that core antibody positivity is associated with increased risk of HCC and liver disease, we don't have the similar data in people with HIV. And in fact, one observational study trying to look at some of those longitudinal outcomes in occult hepatitis B really showed no association between occult hepatitis B and any hepatic inflammation as manifested by increases in liver aminotransferases. What you'll see from the references is these are quite old references. So these are over a decade old, again, in older antiretroviral therapy strategies. And so again, whether or not this is true today is to be seen. And I think it's important to think about these things as we think about the changing landscape of antiretroviral therapy. Now, this is just a snapshot on the top here of some of the antiretroviral therapies, and I'll just call your attention to the Hep B active agents and then some of the class agents that we'll be talking about. So in 1987, the first antiretroviral approved for use in HIV was just zidovudine. And it wasn't really until 1996 where we saw that classic 3-drug antiretroviral regimen being recommended as a strategy to maintain suppression without development of resistance. And in that, it really had that nucleotide backbone, including lamivudine, again, Hep B active agent. And as we move forward during the highly active antiretroviral therapy period, we see additional Hep B active therapies, newer generations of protease inhibitors, and new in-class integrase inhibitors. And again, in about 2013 or so, we see the START trial, which shows a benefit in treating everybody irrespective of CD4 count. And so now you have everybody living with HIV on antiretroviral therapy with that nuke backbone, again, Hep B active therapies. But as we found these integrase inhibitors being very, very effective, high barrier to resistance, the question became, can we get away from some of these triple drug regimens and get away from some of these additional agents to minimize toxicity in people who we anticipate being on these therapies indefinitely? And so in around 2019, you see the approval of 2-drug regimens, so dolutegravir and lamivudine and dolutegravir, rilpivirine, among some, really suggesting that among people who are virologically suppressed, you can transition to now just a 2-drug regimen to maintain that suppression with the idea of being able to avoid any long-term toxicity from unnecessary therapies. And then most exciting, I think, in recent years is the development of long-acting injectable cabotegravir rilpivirine. So cabotegravir, integrase inhibitor, rilpivirine non-nuke, basically really changed the game for how we approach HIV management. But what you can see here is, again, no Hep B active agent in that combination. And so, when my patients had heard this long-acting injectable approved, they were very excited. And what we found with the Atlas and FLAIR trials is that with the lead-in of 1 month of oral therapies of the cabotegravir rilpivirine, we could then switch to every 4-week injectable agents, and it would be non-inferior to the classic 3-drug regimen. However, these 2 trials did exclude people with chronic hepatitis B as defined by surface antigen positivity, but they included people who had core antibody positivity. So again, excluded chronic hepatitis B, but did not exclude those who, with prior exposure to hepatitis B. And while the adverse events that were reported were largely injection site reaction, there was no explicit report of any hepatitis B reactivation in these trials. Additionally, what I think is very unique and attractive about the long-acting injectables is that we've seen with both qualitative studies and with our patient experience that these long-acting injectables really do eliminate the daily reminder of people living with HIV by removing that need to take that daily pill. And so really decreasing the stigma associated with living with HIV, decreasing that fear of inadvertent HIV disclosure if people are going through the medicine cabinet, going through luggage while traveling, and potentially improving adherence by taking away the need to have that classic 95% plus adherence to pill therapies to maintain suppression. And that was one of the really interesting parts is, we know that with Atlas and FLAIR, we can use these long-acting injectables to maintain HIV suppression, but what about treating HIV viremia? And while this is an off-label use right now, it was quickly picked up because there are certain patient populations that just cannot be suppressed with our classic antiretroviral therapies. And so this seemed like a really great opportunity to trial. And so this is the Ward 86 clinical cohort out of San Francisco, and it had an observational cohort where they essentially offered this long-acting injectable to people with detectable viremia, with the caveat that this is an off-label use and that they would need to come back for those Q4 week intervals. Once achieved, HIV suppression could then go to Q8 weeks as is currently approved. And among the 57 of people with HIV with detectable viremia at the start of these long-acting injectables, at 33 weeks, there was only 1.5% virologic failures, which is what is seen in those clinical trials. So really successful in achieving HIV suppression among a population that was unable to achieve that with the standard oral antiretroviral therapies. And in this observational cohort, they did include people with chronic hepatitis B, but they required them to take a Hep B active antiretroviral therapy, so usually tenofovir alafenamide and emtricitabine. But again, this is a patient population that was unable to take oral therapies long enough to suppress HIV. So this agreement to take the Hep B active therapies would raise some question about the efficacy. But again, as in this group, they reported no Hep B viremia was observed, with the caveat that it was not systematically evaluated. So we can see that these therapies are effective at maintaining HIV suppression, even though some of them may not have hepatitis B activity. Not clear at this point how that impacts ongoing control. Yet there was a really interesting abstract that we saw last year coming out of the Liver Congress that I think is worth mentioning before launching into those clinical case discussions. So this is data from an Italian cohort among people with HIV with no detectable surface antigen, but detectable core antibody. And in this group, they were switching from a tenofovir-based antiretroviral regimen to a non-tenofovir regimen. So this could include lamivudine, or it could be without lamivudine. And they looked at, among those people switching, how many of them had hepatitis B reactivation by the 12-month mark following that switch. And they defined hepatitis B reactivation as any detectable DNA using a highly sensitive assay. So essentially, 1 international unit per milliliter would be qualified as a hepatitis B reactivation, or a 2-fold increase from the baseline. And so among these 101 people with HIV that switched off tenofovir containing regimens, 73 went on to an antiretroviral regimen with lamivudine, again, Hep B active agent. 28 went on to a therapy without lamivudine or other hepatitis B active therapy. What's interesting is that even at baseline, when they evaluated this, people still on that tenofovir-based antiretroviral therapy, 34 had detectable hepatitis B DNA by their assays. But again, quite low viremia with a median of 2 international units per milliliter. And so when they looked at everybody at the 12-month mark, they found that 40 people qualified as having this hepatitis B reactivation by their definition. And the hepatitis B, that DNA, the median level was 4, again, from this highly sensitive assay with a range, or an interquartile range of 2 to 13. And among those 40 with that hepatitis B reactivation definition, 10 of them had elevated liver aminotransferases above the 40 units per liter. And what they found was that among people with detectable hepatitis B DNA at baseline, again, prior to switch, a surface antibody less than 100 international units per milliliter was associated with detectable DNA. And at that follow-up point, 12 months post-switch, they found that the hepatitis B reactivation did not differ whether or not that person was on lamivudine-based therapies. Kind of interesting there. And then the only factor that they found to be associated with hepatitis B reactivation was a nadir CD4 count of 100. So some historical component of the patient's history suggesting that their CD4 count at some point was as low as less than 100. And so they conclude this poster presentation by saying these highly sensitive assays are needed to inform the optimal management of people with HIV and detectable DNA. But I'm not quite sure we know the optimal therapy for these patients. And so what I'd like to do is go into 3 clinical scenarios to really work through how clinicians, how our basic scientists, and how other folks are thinking about approaching patients with these issues. So these are all cases that are presented in the literature here. So I'll move forward here. So this is a first case series. This was presented back at the National ID Conference last year. And this was a retrospective single center case series of people with HIV switching to long-acting injectable cabotegravir rilpivirine. And in this group, they had 149 people who switched. And of those, 25.5% had detectable core antibody without any detectable surface antigen. And then of those people with core antibody positivity, 3 ultimately developed hepatitis B viremia. And so here are some of the case details. So in the first patient here, prior to switch to that cabotegravir rilpivirine, they had detectable surface antibody at the 6.5 threshold. So by qualitative assay, that would be negative. They had detectable core antibody and no detectable surface antigen with no detectable hepatitis B DNA prior to switch. They were fully suppressed on rilpivirine, lamivudine, tenofovir alafenamide, and dolutegravir with a decent CD4 count of 677. And prior to switch, this person completed not 1 but 2 series of the Hendrix B vaccine to attempt to achieve hepatitis B immunity. So following that 4-week lead-in with that oral therapy, they had their first dose of the injectable long-acting cabotegravir rilpivirine. And labs at that time found that the hepatitis B DNA was detected, but less than 10, the threshold of quantitation. They didn't do anything, continued on for the second dose, and at that point found that the DNA had increased to 95, but no detectable surface antigen. That prompted the clinicians to switch therapies to oral bictegravir, tenofovir alafenamide, and emtricitabine. So again, a Hep B active therapy, back to oral therapy. Subsequent month had no detectable hepatitis B DNA. Similar case, and patient B had no detectable surface antibody, but that isolated core antibody positivity. No detectable DNA prior to that antiretroviral switch, and was on dolutegravir, abacavir, and lamivudine. Again, lamivudine was the Hep B active therapy prior to switch, fully suppressed from an HIV standpoint. CD4 count, good, again, 351, but no known vaccine history. And in this person, following that oral lead-in therapy, had one dose of the long-acting cabotegravir or pivirine. Prior to the next dose, had a hepatitis B DNA level of 101. That prompted the clinicians to start Hep B active therapy, and then subsequently measured the hepatitis B DNA about a month later, not detectable, with no detectable surface antigen. And at that point, they consolidated therapy to a fixed tablet combination, again, the bictegravir, tenofovir, and emtricitabine. And then finally, the third patient did have detectable surface antibody above that threshold of 10 for the qualitative assays, and even above that 100 threshold that we try and achieve when vaccinating core antibody patients. Detectable core, no detectable surface antigen, no detectable hepatitis B DNA prior to that switch. They were not fully suppressed, nearly fully suppressed on a boosted darunavir, bictegravir, tenofovir, and emtricitabine regimen. So again, Hep B active therapies, CD4 count of 432, low level viremia at 110, and the patient did not have hepatitis B vaccine in their history. After that oral lead-in, hepatitis B DNA checked, less than 10 but detected. No Hep B active therapy was initiated. The subsequent DNA, 14, with no detectable surface antigen. And again, at month 3, less than 10 detected, but no changes in therapy. And the authors of this abstract note that this was based on clinician and patient discussion about management of their care. So low-level detected DNA without any change in therapy. And so what's interesting to note is that of these 3 cases, there was no liver aminotransferase elevation, so no evidence of liver inflammation based on these laboratory values, and patients were asymptomatic otherwise. And so the questions I'd like to pause here and ask of our experts and of our group in general is, particularly for both people with HIV and otherwise, what is your approach for monitoring for hepatitis B reactivation and people who have poor antibody positivity? And if you treat HIV among those people on long-acting injectables, do you have a special approach? Second question I'd like to pose is, what do you consider a clinically significant hepatitis B reactivation? And third, what is your threshold for adding a hepatitis B active agent in somebody who has the detectable DNA without surface antigen positivity? And I'll pause there.
I guess I could talk. Sorry. So thanks for presenting this, Jesse. It's like having palpitations as you present this, because first of all, I think for years we've been very comfortable in hepatology, knowing that these patients we don't have to worry too much about for their hepatitis B because they've been on Hep B active agents. And now that some of them are coming off, it definitely keeps us up at night a little. I think conceptually where I'm struggling with the whole field here is that there's such a higher rate of occult chronic hepatitis B in your population than there is in a normal sort of isolated core population, that in the couple studies that you showed, you're looking at somewhere between 7 and 30% of these patients were surface antigen negative with detectable viremia, which is absurdly high compared to what you would normally see, where it would be less than 1%, let's say. So my argument is that those patients should never get taken off of treatment. From a hepatology perspective, I feel like they should be on something. If they have viremia, you don't take them off of the treatment. If you want to treat the HIV differently, fine, but keep them on something for Hep B. And I think that if they're somebody, the first couple cases in the last slide that you had, where those first 2 patients were no detectable Hep B going in, I mean, that's reasonable to consider it. And I might argue that you're picking up these quote unquote reactivations that we would never see clinically because we don't check viral loads every month on those patients. And maybe we check them every 3 months, and they could have a little flare of virus that then subsides, and we would never detect it, and it wasn't clinically significant. So I think to answer the second question there, a clinically significant reactivation would probably be one that's associated with inflammation. So it's hard to argue that those patients absolutely needed to be put back on medication yet. But the 2 points I think are important to tell those patients if you're going to do that and not put them on antivirals for Hep B are, one, their HIV may be controlled, but their Hep B is not, and they can spread it. So they need to be making sure their partners are vaccinated or using protection. The second is that they're going to be at risk of liver cancer, so they need surveillance. And I think you definitely need to hit home about liver cancer screening in those patients, especially if you take them off of antivirals. So those are my points. Happy to hear others.
I just had a question, and I don't know if Dr. Finkel, you may be able to answer this, but I was interested in your presentation on one of the first slides, Dr. Torgerson, on the longitudinal outcomes of occult hepatitis B being low damage. Is that just in the HIV population, or is that just mono-infected as well? And is that something that we see in practice too? Because I thought that was something that I was a little surprised by.
Yeah, it certainly is surprising. In that study, it was an observational evaluation of banked samples. And so it's about 200 people followed longitudinally with those banked samples to identify any increase in the liver immunotransferases. So based on that sample size alone in the observational manner, they didn't see any association with increased hepatic inflammation by those laboratory parameters, with the caveat that that is only, again, 200 people, an interval, time point or an interval, marker, if you will, of subsequent liver damage. And so that was, again, in 2006, 2007 when it was completed. So I think it's certainly the data needs to be reevaluated in the setting of Hep C treatments widely available, and particularly with the newer antiretroviral therapies to get a sense if that's still the case.
Thank you.
I know, Dr. Finkel, I appreciate that. And I sort of expected it from the hepatologist perspective, because you do see these incredibly frightening, very severe end of the spectrum cases. I think, what sometimes my bias comes up is that my patients say this is the first time they felt that they can be, live stigma free or have that decrease in stigma by getting away from those oral therapies. And so I wince when I see, a hepatitis B DNA level listed here as that 94 or less than 10 detected, and you sort of question, what is the right strategy, knowing that we don't have currently any data to guide that. But I see Katie and Myra, I'd love to hear your input from how you manage your folks in similar situations.
Thanks for an interesting conversation for sure. I guess I'm the opposite of Dr. Finkel in the sense that I am really excited about the long-acting agents for people that are living with HIV, for people that are isolated core antibody with no history of surface antigen or detectable DNA. We just monitor LFTs. We don't even do another DNA, but after this conversation, I might have to. And so in the same realm, I'm just looking at any transaminitis for clinically significant HBV. We don't have the highly sensitive DNA. If I did and saw it was 10, I probably would not switch. So I guess my threshold is similar to, thinking about Hep B in the general population, having signs of inflammation to switch or to add an agent. I think one question is, you suggested in the beginning that surface antibody is possibly helpful in the presence of core antibody. And I know that we've been having that conversation along, and in that last case scenario, the third patient did well because they had surface antibody. Is that the suggestion?
That's the suggestion.
Yeah. Back to the question of whether we should be vaccinating people with core antibody.
Yeah, I was a little surprised about that too, honestly, because that's not been our practice in mono-infected patients. But I think that to me, it raises a potential trial you could do where you use HBig instead of vaccine, just because maybe you give a dose of HBig as your starting cabo, and then that may protect them from that couple months of flaring to consume that. Just a thought for something you could look at in the future.
Dr. Torgerson, is it your practice to immunize people with isolated core that are living with HIV?
Yeah, it's actually guideline recommendations for management of people with HIV and isolated core is that vaccination, with the idea that if you achieve that 100 or higher threshold, that perhaps you can prevent that reactivation. There are some data that, again, that suggests that those with isolated core may have some, additional progressive fibrosis, which is in contrast to that occult hepatitis B study from 2007 or so with regards to that inflammation observed. So it certainly is my practice to try. I struggle to get the quantitative surface antibody in our lab. That's often a send out and a bit of a challenge. Dr. Finkel at Jefferson, do you guys default to a quantitative surface antibody, or are you qualitative?
Usually it's qualitative, but we could get the quantitative if you want. Jesse, can I ask, were these in the study that you were just going over, was there any control for alcohol use when switching over? Because I
know a
little bit about the diagnostics being confused by alcohol use in this population.
Yeah, absolutely. A fantastic point. And that's particularly in these abstracts that have these really intriguing results. They don't have a lot of data on what other etiologies may be contributing to progressive liver disease here.
Right.
Oh, Myra, I see you talking, but I can't hear you. Or she's not able to hear you still. I can't. Can anybody else go?
No, it sounds like your audio is not working on your computer. Do you have headphones nearby or something, that Bluetooth that might be connecting instead of your computer? Oh, I think she said she's going to log back in.
Okay.
Yeah, thanks, Dr. Rutland. I wonder too, maybe Melissa, if you could maybe comment on what your thoughts might be on, the stigma associated with the daily medication reminder, and what your thoughts are with that. I know Hep B medication isn't quite there yet, but maybe in the future this could be. So it'd be great to get your thoughts on that, if you don't mind.
I'm sorry, you mean the daily medication for like entecavir for hepatitis B?
Yeah. So these, maybe Jesse, you can explain the difference between like the HIV medications and,
Right.
and what the Hep B medications are, to give that context.
Yeah, so a lot of prior to these two drug regimens, long-acting injectable, a lot of our standard HIV therapies had a backbone that had Hep B active agent. And with these, particularly the long-acting and injectable, there's qualitative data suggesting that this removing the need for a daily pill will help decrease the stigma associated with living with HIV, decrease fear of inadvertent disclosure, and potentially improve adherence.
No, I think I think it's less the taking the pill every day than just the diagnosis itself that creates the stigma. So I mean, I'm just speaking from my own perspective. If you it's just one, for example, I take entecavir, it's just one pill a day, so the pill burden is not huge, and then most of us take other pills anyway. So for me, it's not a huge burden or a huge stigma, but possibly for someone who has both HIV, HBV co-infection, that might be a little more problematic. I'm not sure. I can't speak to that.
Thanks, Melissa. That's helpful. Appreciate it.
Still can't hear Dr. Rutland.
Dr. Rutland, are you?
Can you hear me now?
Yes, yay.
Okay, great. Maybe I just needed to use my outdoor voice. You know, I have a few concerns. I've always been very hesitant to consider even a long-acting injectable for my patients who were even who had even a positive core. And when I've attended any of the conferences where they were introducing the long-acting injectables and having discussions about them, that is inevitably always my question: what studies have they done on patients who have a positive HBV core, and what are their concerns? And typically the answer I get is, you know, we don't recommend it. So, you know, that I've kind of taken my lead from that, but I also had the same concerns that Dr. Finkel alluded to. What, you know, what considerations do we have to have for patients who have lifestyles we can't control, for their lifestyle, their choices, their BMI, their dietary considerations? You know, all of those things can negatively impact their liver function. And, you know, even just looking at the long-acting injectables alone, there have been studies where they've shown, now granted, this is not with the Hep B, but just with the HIV infection, there have been blips in the HIV virus with some of these, with, you know, the present long-acting that's on the market now. And I've seen that in my practice, right? So I've had a couple of patients who were doing great, they were undetectable, and then all of a sudden I see this blip, and I know that they've come in consistently. And so what will that mean for somebody who could potentially have hepatitis B, you know, and they become resistant to their HIV antiretroviral medication, and what's that going to do to their Hep B status? You know, I think that there's just too many questions for me to risk that with my patient. So I'm really very conservative in my approach and my thought process. I do think it's extremely interesting that, you know, you're sharing that if you could vaccinate patients who have a positive core and reach a greater than 100 level, that's a method. I had not been vaccinating my patients who are core positive, you know, based on some of the information I've learned here. So, you know, I will probably change that practice. But again, I think I'm a little conservative in my approach.
Thank you for sharing. That's, I think I've heard all spectrums of that conversation from my colleagues, and I certainly think that there's no one right or one wrong answer, and I do think that there'll be additional data in our fall conferences coming out that will hopefully add to this conversation. I think what's also interesting is thinking about equity in these long-acting injectables in resource-poor areas where you may not have the luxury of being able to follow DNAs or change therapies or offer you know, a daily pill as a viable alternative for HIV suppression. But certainly, I think an area that will hopefully garner additional discussion as we move forward. So I can move on to the next case unless anybody else has any thoughts, comments about this person in particular.
I just ask a quick thing, and maybe this is more your expertise rather than this case series, but when you're discussing sort of this Hep B reactivation risk and when you're switching patients, is this also a case if you have a naive HIV patient who you're starting on that therapy, or is this more a unique problem for switch?
This is, since the long-acting injectable is only FDA approved for switch therapies, they're usually coming in suppressed, but I still have the conversation of these are case reports, the absolute risk is unclear. I like to overtly say I don't know what the surface antibody will, what level will be clearly protective, but let's get a quantitative to inform our guidance and go from there. And so far, everybody I've had, as you know, they're integrally involved in their clinical decision making and very comfortable with that so far.
Thanks.
And just a clarifying question, the use of the vaccine in isolated core is only for co-infected. Is that correct? In terms
Correct.
of-
Those are,
just
yeah,
wanted
those
to
are
clarify.
HIV specific guidelines. Yeah.
Okay, perfect. I think there is research in the Hep B space, but I don't think that is that correct, Dr. Finkel, that it's not an official recommendation at this time?
Correct. Yeah, we don't recommend it, in fact, for mono-infected
Okay.
or for core positive isolated. Sure.
Okay, thank you. I just wanted to clarify that point so there's not any confusion. Thank you.
So let's see here. So I'd like to move on to a second case here. This again was a published case report of hepatitis B in people with HIV. So this is a 33-year-old man who presented with HIV virologic failure in the setting of reported antiretroviral therapy use. He had been on tenofovir alafenamide, emtricitabine, and rilpivirine, and while was initially suppressed on that regimen with those two Hep B active therapies, ultimately developed HIV virologic failure. And in that had a number of HIV resistance mutations here, which essentially conferred resistance to emtricitabine, lamivudine, tenofovir, efavirenz, and some low-level rilpivirine resistance here. And at the time of presentation, he had a CD4 count of 300 and detectable HIV viremia at 30,000. And around that evaluation time, he's noted to be Hep B non-immune, so no surface antigen, no core antibody, no surface antibody. And following that evaluation, underwent vaccination with the Energix B vaccine at standard dosing, but at non-standard intervals at the 0, 8, and 11 months, as opposed to the 0, 1, and 6 months. But 3 months after completing that series, had a qualitative assay that would be equivalent with reactive surface antibody at that 41 threshold. And after that was also found to have an acute hepatitis C diagnosis with viremia detectable at 386,000 there. And so the patient and the provider ultimately planned to have a switch in their antiretroviral therapy, and they were switched to dolutegravir and boosted darunavir. And so neither of these therapies cover hepatitis B at all, but has been used as a salvage regimen in people with drug resistance. The case report does describe the person's baseline ALT, AST, bilirubin, INR as quote unquote normal. But as we see in the 4-month follow-up, he presented to a hospital with a pretty significant transaminitis and ALT reported 2,640, elevated bilirubin, coagulopathy with an INR of 3.1, and a Hep B DNA newly positive at 380 million. Not surprisingly, detectable surface antigen and a Hep B core IgM that was positive. At that time, HIV RNA was not detectable and Hep C RNA was not detectable, presumably from adherence to HIV therapy and spontaneous clearance, as the case report does not indicate the patient received Hep C therapy in that interval period. So with this presentation of fulminant liver failure due to acute hepatitis B, the patient ultimately had Hep B active therapy started with tenofovir alafenamide added. He underwent an evaluation for liver transplant, but was ultimately found to not need that and was discharged home about 2 weeks later. In that follow-up following the hospitalization around month 12, had HIV therapy consolidated to fixed tablet combination of bictegravir, tenofovir alafenamide, and emtricitabine. And at that point, hepatitis B DNA was not detectable. And so with this person who was vaccinated against hepatitis B before switching to a non-Hep B active antiretroviral regimen, who developed acute hepatitis B infection by those serologies, I'm wondering how you think about similar patients in your practice, and do you require hepatitis B vaccination prior to switching to a non-Hep B active antiretroviral therapy, whether it be long-acting injectable or the 2-drug oral regimens? And then how do you approach evaluation of hepatitis B immune status? Do you use qualitative, quantitative assessments? I think we alluded to some of that with the last case. And then do you follow up with any annual evaluation of hepatitis B surface antibody positivity?
happy to address first if you want.
Thank you.
I think the cardinal flaw in this case is the absence of a Hep B DNA to start. And you know, while it may not be super high on your agenda when you've got a negative triple screen like that, you know, we do see false negative serological testing in HIV positive patients for Hep B. I suspect this patient was simultaneously co-infected with Hep B and C. And we see this in our practice where we have patients that are co-infected. There usually is, when I say co-infected with B and C, not necessarily HIV, that one of them tends to dominate. And so if you're viremic with Hep C, you're usually not that viremic for Hep B and vice versa. So there's some kind of competitive viral mechanisms occurring there. So I suspect they were co-infected with B and C, had a cold B, and then, you know, like as you saw here, probably had spontaneous clearance of the C, and then B woke up. I don't think it had anything to do with the HIV regimen. And I'm not sure how it would, because if anything, the immune reconstitution would be potentially protective against flare. So I think they had to have been infected simultaneously to start. And you know, the vaccine was probably useless because they were already infected in that case, which is the only way I could explain this case happening.
That's really helpful, because I think a lot of the clinical management too is, when do you assess the hepatitis B status when you're making these switches, and particularly if they're already on a Hep B active agent, like this person was on tenofovir and emtricitabine at the time of switch. Is there utility in checking that DNA if they're on that Hep B active therapy? But I think, as that interesting abstract showed, with some detectable DNA, perhaps having that baseline at the very least to guide the next steps would be a good reference point.
Right. I mean, you would expect a core positive there, but you know, not always. And I think it's important that you get PCR testing for B and C in these patients if you're unsure of their status.
Thank you.
Just to clarify, no one thinks these were new infections?
I'm sorry, Akita, I broke up for a second.
No one thinks they're new infections? B and C?
The C we thought was new, or at least newly known. I think they probably got B and C at the same time. That's my theory.
Okay, my question was just whether, you know, there was recent risk factors.
Yeah, in the case report, they do describe Hep B acquisition risk factors in this person, but don't elaborate further on timing of both Hep C diagnosis relative to this Hep B flare that brought them to the hospital. But definitely, I see your point.
Thanks.
All right, great. I have one last case, and I know we're almost at the end, so I'll quickly move forward here. This is another published report of a 47-year-old man with HIV, extensive antiretroviral exposure history, uncontrolled substance use disorder, who presented with failure to thrive. They essentially had HIV diagnosed decades ago and were never virologically suppressed on standard oral therapies. As you can imagine, multiple resistance for HIV therapies, including lamivudine, emtricitabine, tenofovir, efavirenz. And so their antiretroviral therapy at presentation was prescribed as etravirine, dolutegravir, and boosted darunavir, in addition to trimethoprim sulfamethoxazole for prevention for pneumocystis pneumonia, and weekly azithromycin for prevention against disseminated Mycobacterium avium intracellulare, so opportunistic infections. It was quite profoundly immunosuppressed at the CD4 count of 10, and not surprisingly, a detectable HIV viremia at 300,000. At this evaluation, the person had detectable Hep C antibody with no viremia, and was isolated core antibody positive with Hep B, no Hep B detected, no E antigen, and also no E antibody detection at that time. And so as an off-label use, this person was started on long-acting cabotegravir rilpivirine, again, as salvage therapy, as this person was approaching hospice, being unable to control their HIV for so many decades with standard therapies. And so they had baseline dose, a dose a month later, and dose at month 2. And at month 2, they were found to have suppressed HIV viremia. So going from 300,000 to 40 copies per milliliter is quite a impressive decline. CD4 counts was only 2023, but again, not surprising in only 2 months. But at that point, the ALT and AST were described as mildly elevated, and the patient also complained of fever and abdominal distension. The patient was ultimately diagnosed with disseminated Mycobacterium avium intracellularity, and labs at that 2-month mark showed, again, hepatitis B reactivation with detectable surface antigen, DNA, and quite a high viral load, presumably with the detection of E antigen. So Hep B active therapy was started here as well. And so, unfortunately, the patient continued to have a lot of symptoms related to the disseminated Mycobacterium avium and this reactivation of hepatitis B, despite reporting adherence to the oral therapies, although hepatitis B remained detectable with no evidence of lamivudine resistance, again, suggesting that perhaps the patient was taking it as regularly as needed. The patient ultimately seemed to maintain HIV suppression, but not Hep B suppression. So this is a very challenging case where you're really left with not many options to control one or the other virus, and perhaps the clinicians were thinking not to have perfect be the enemy of the good and attempt some salvage regimens here. The questions I thought were interesting here is, are there scenarios where people would consider long-acting injectable therapies or just 2-drug regimens, or I guess long-acting injectables, in people with chronic hepatitis B, particularly if there's issues with regular adherence? And then for hepatitis B, what degree of adherence is needed for Hep B suppression, knowing that for HIV suppression, again, classic teaching is at least 95% or higher adherence to maintain suppression. So I'll stop there. I see Dr. Finkel is already unmuted.
Figured I'd be called on. So, I mean, I think I have a problem not offering antivirals for B in somebody with chronic B. You know, it's different. I think for the isolated core patient, I could get behind the idea of not giving them medication as long as they're not viremic and treating the HIV however you want. But if you have chronic Hep B that's viremic and surface antigen positive, and you have HIV co-infection, I'm not so much, I mean, I'm worried that they're going to get liver failure, but I'm more worried they're going to get liver cancer, and I feel like they should be treated for their B to lower that risk. So I think you can do what you want with the HIV, but they should stay on TAF or something for their HIV or for HBV, sorry. With your case here that you're showing, my suspicion is, my GI bias here, that they had the disseminated MAI involving their gut, and they weren't absorbing the pills. And that's why the HIV is controlled by the injectable, but the Hep B is not controlled by the oral. So I think in that case, you just have to focus on immune reconstitution and treating the MAI. And at some point, you can get back to the hepatitis B if they haven't developed liver failure by then. And then for the last question here, I think, you know, we would generally see 90% or higher, I think would be our target. You know, I don't know that I could give you an exact number on that, but I think you need a pretty good amount of therapy. It's a little lower maybe with the higher barrier threshold antivirals. With the older drugs, for sure, you needed high adherence rate. I think at least 90% for entecavir or tenofovir based therapy would be the goal. Any other opinions on that one?
I do have a patient in a very similar scenario who has been living with HIV and hepatitis B for 10 years. And we have tried everything for both, and he retakes them for a day or two and can't possibly go on. So his HIV and Hep B are both continuing to get worse. And when his CD4 started to get in the 200s, I did offer him Cabenuva, and he's doing great on Cabenuva. So for the first time in 8 years, his viral load is undetectable, and his hepatitis B is still in the millions, with significant inflammation. And so I don't know. I mean, I give him the consequences. We've talked about this case in this echo session, and I've talked about him with Dr. Finkel before. We're continuing to try the oral therapy for hepatitis B, and last month he filled the script twice, and he's taken a couple of days of it here and there. But yes, sometimes these are really hard decisions.
maybe a temporizing measure to control HIV with a long-acting injectable to address the underlying factors preventing the ability to take those Hep B meds daily, but certainly is a tough spot to be in.
I do think stigma really contributes. And so I think having that, knowing that his HIV is controlled, we can have a much freer conversation about Hep B without the Hep B medicine being the HIV medicine. In most patients, it's so much easier, the one pill for both, but in his scenario, I think separate them is going to be helpful.
Good point.
And Katie, you might want to also just consider a more thorough GI evaluation, gastric biopsies of their intestinal tract, making sure there's no opportunistic infections contributing to the tolerance of the Hep B drugs, perhaps.
It's a good point. Yeah. Great. Thank you.
Well, excellent. Well, I think, the last two slides are just reiterating some of the knowledge gaps, and that we don't know the absolute risk of Hep B reactivation with these switches, but certainly hope that data will be coming soon, particularly as those Atlas and FLAIR trials look at some of those bank samples to see what that risk may actually be. Optimal monitoring strategies. Katie, I agree with you. I tend to look just at liver aminotransferases and not go searching for that Hep B DNA as a standard monitoring strategy for people who I switch off hepatitis B active therapy. But again, not knowing what exactly the threshold is to start that therapy in people with reactivation, I think is unclear. I think a DNA level of 1 is probably too low for me to start, but certainly don't know where that threshold is. So just from my current strategy, that's not endorsed by anyone in particular other than myself. I do counsel patients on the risk of reactivation based on those case reports. I do offer vaccination for people with HIV and isolated antibody core positivity or a non-immune. I try and confirm to achieve that quantitative level of over 100 for a surface antibody. I monitor liver aminotransferases every 3 months when I switch to non-Hep B active therapies, and then check additional Hep B DNA and surface antigen on those who are elevated. And then I've started to look at annual quantitative levels of hepatitis B surface antibody. As we know, people with HIV can have that immune waning and offer them revaccination if needed or negative. And with that, that's it. So I thank you so much for everybody's contributions. It's been fantastic.
Thank you. Thank you so much, Dr. Torgerson, for that excellent presentation and those cases to walk us through really important topics that are very timely in terms of discussion, I think. Just a couple of quick announcements as we conclude. Anusha put in the chat the survey for CME credits. Our last ECHO session of the year will be on October 26th at 12 p.m. Dr. Sherry Cohen will be leading that session, as I will be attending the Africa Hepatitis Summit. We will be at ASLD in November. If anyone is in this room planning to attend, feel free to reach out. We would love to connect with you all. And we'll be sure to share the new WHO guidelines when they are available, either at ASLD or the Africa Hepatitis Summit with everyone. But we'll be sending out notes in the recording of the meeting for today, and we'll look forward to seeing you in October. Thanks, everybody. Have a great rest of the week.
Thank you.
Thank you. Bye-bye.